Today we'll take a case based try to understand an overview on approach for some sort of the toxidrome. We'll try to get some information on the therapeutic options which are available for OP poisoning, atropine, glycopyrrolate, enzymes, when to use, when not to use, and also the evidence backing up all these things. Along with that, so we'll narrow down our case discussion for OP-induced delayed neuropathy intermediate syndrome. So how we can identify what are the differences between their clinical manifestation, and we'll try to narrow down with some sort of the take-home message. So this OP poisoning case like discussion most commonly going to be one of the case for Indian critical care or internal medicine based exit exams. But when it comes to EDIC part 2, you might not get some sort of a pesticide injection with OP compound and all. But so there are questions which are going to be in and around OP poisoning. May not be like a case-based discussion, but you can expect some questions in relation to pathophysiology, some therapeutic options and all. So we'll go ahead with the case based discussion on OP poisoning. So in the ER, a 27-year-old male farm worker is brought to emergency department by relatives. He was found unconscious with frothing from mouth, profuse oral and nasal secretions, and passed urine and stools in cloths. His vitals on arrival: heart rate 52 per minute, blood pressure 98 by 56, respiratory rate is 26 per minute, labored breathing. So it's saturating around 84% on room air. So GCS is E2V1M3. Pupils pinpoint, bilaterally reactive. So strong garlic or petroleum smell noted in terms of the odor. So family provides an empty pesticide bottle. So commonly used in the local agriculture. See, most of the data has been given here. So only thing is you need to narrow down and you need to put everything together into some sort of the toxidrome. So this is the patient, so young, farming background, who presented with some sort of bradycardia, borderline blood pressure, so altered sensorium with a drop in some like GCS, pinpoint pupil. So how you are going to narrow down? Okay. So how to approach to a patient with possible toxidrome? So structured differential diagnosis strategy you need to follow when you answer these kind of questions. When a patient arrives with altered sensorium, abnormal vitals plus autonomic signs, your first job is to recognize the toxidrome, because pattern recognition is the fastest way to narrow the differential diagnosis, and you can start the antidote as a therapy. So this should be your approach when you have a toxidrome based case discussion. So first identify the dominant physiological system involved. Ask yourself, is the primary abnormality cholinergic crisis, anticholinergic crisis, sympathomimetic excess, opioid effect, sedative hypnotic effect, so serotonergic toxicity, hallucinogenic, dissociative toxicity. So this directs the rest of your evaluation. So these are some of the toxidromes. We will not go in depth, but these are the headings you need to understand. So what toxidrome patient is going to be fit in. So next step, look for signature clues. So these are the fastest pattern recognition features. So see the pupil size, most important bedside discriminator. So if patient is having a pinpoint pupil, that is miosis, so likely toxidrome is going to be opioid, organophosphate, clonidine, or sedative. Okay. If patient is having a dilated, that is a mydriatic pupil, so anticholinergic, sympathomimetic, serotonin syndrome, withdrawal state. Very, very important table. So this helps in narrowing down further your differential diagnosis. This patient, our patient, so having a meiotic pupil, so toxidromes with miosis become immediately relevant. So you can exclude the toxidromes which are going to having a mydriasis kind of this one. Okay. So next, skin signs, dry versus wet. So findings: dry skin, dry mucosa, no sweating, anticholinergic toxidrome. Sweaty, wet skin, copious secretion, cholinergic, sympathomimetic, serotonergic syndrome as the toxidrome. So our patient again, profuse secretion. So again, it is fitting into cholinergic toxidrome. So next, see the heart rate. So bradycardia versus tachycardia. So bradycardia fit into OP poisoning, opioids, clonidine, sedatives. So tachycardia, sympathomimetic, anticholinergic, serotonergic syndrome or withdrawal syndrome. Okay. So patient again having a bradycardia, it exclude anticholinergic and sympathomimetic toxidrome. So we reached up to so certain level in terms of our differential diagnosis. Next, see the respiratory pattern. Brad apnea, so move towards the differential of opioids and sedatives. So tachypnea with secretion, so sometimes organophosphate poisoning, secretion will be there. So initially they will have so tachypnea, hyperthermia plus tachypnea, serotonergic syndrome, apnea, so hypoventilating, opioid or benzodiazepine overdosage. Again, the patient is having tachypnea with secretion. So OP poisoning is more likely as compared to opioid or sedative. So again, this fit into the OP poisoning as a toxidrome. So mental status, coma, bradypnea, meiosis, opioids. So delirium, mydriasis, dry skin, anticholinergic toxidrome. So agitation, mydriasis, sweating, sympathomimetic toxidrome. Confusion, sweating plus tremor or clonus, serotonergic syndrome. Confusion plus sweating, salivation, diarrhea, cholinergic like toxidrome. So our patient altered sensorium, sweating plus salivation again is fitting into cholinergic toxidrome, that is the OP poisoning. So next, so identify the dominant organ system features. So when it comes to cholinergic toxidrome, that is organophosphate or carbamate, we have a muscarinic manifestation. We have the mnemonic, that is like dumbbells. So diarrhea, urination, meiosis, so bronchoria, bradycardia, emesis, lacrimation, sweating, salivation. So everywhere secretion is increased. So nicotinic manifestation, so fasciculation, muscle weakness, CNS, so confusion, seizures they can have. So this exactly matches your patient in terms of the OP poisoning, that is the cholinergic toxidrome. So this is the table again. So vital sign matrix for your quick revision: pupil, skin, heart rate, BP, bowel, mentation. So you can categorize them on their manifestation into any sort of toxidrome. So just go through this table. It is an high yield Viva table which you can have for the quick revision. So your patient fits exactly into cholinergic toxidrome because of all these clinical manifestation. So what is the pathophysiology? Next examiner can ask you to just briefly tell what exactly happens in organophosphate poisoning. So OP compounds are irreversibly inhibit the acetylcholinesterase enzyme by phosphorylating the enzyme. So this causes accumulation of acetylcholine at muscarinic, nicotinic, CNS synapses. So when they have a muscarinic excess, they will have a bronchoria, bronchospasm, okay, bradycardia, hypotension, secretion. So nicotinic excess of the acetylcholine. So they will have fasciculation, neuromuscular weakness, respiratory muscle paralysis. So CNS effect, they will have agitation, seizure, and coma. So with the time, so OP acetylcholinesterase enzyme complex is going to get aged, so making the inhibition irreversible. So before that only we need to give oximes. So persistent nicotinic dysfunction leads to intermediate syndrome. So somewhere around 24 to 96 hours. So inhibition of neuropathy target esterase, that is called NTE, causes delayed axonal neuropathy in the 1 to 3 weeks. So this is an overview on the pathophysiological background of the OP poisoning. So maybe examiner expect you to briefly tell what is your understanding in terms of the OP poisoning like pathophysiology. This is how acetylcholine so is going to build up because OP organophosphate compounds are going to inhibit acetylcholinesterase. So there is no breakdown of acetylcholine into choline and acetic acid. So all this acetylcholine will have an effect on the muscarinic, nicotinic and CNS effect. So we are going to have the symptoms based on the accumulation of the acetylcholine on all these end receptors. Okay. So step 5. So use the 3-question narrowing tool for Viva. So dry or wet. Wet eliminates the anticholinergic. Pupils. Meiosis eliminates the anticholinergic and sympathomimetic. Okay. So heart rate, bradycardia removes opioid, but not it. But opioids usually they have a dry secretion, organophosphate, profuse secretion. So thus OP poisoning is the most likely diagnosis in this particular patient. So next, what is your clinical approach in this patient? So we have some sort of differential diagnosis and we are narrowed down towards the diagnosis, that is the OP poisoning. So that is the cholinergic crisis. How you are going to approach in this patient? So again, give the answer in a structured way, very, very important. So airway, Assess the patency, likely compromised due to secretion and low GCS. So frequent suctioning, prepare for early intubation when the GCS is less than 8, persistent hypoxia, inability to handle the secretion, so impending respiratory failure. So remember, so OP poisoning is one of the few toxic emergencies where early intubation improves the survival. If you take care of the respiratory system and support the weakened respiratory muscle and the secretion by taking care of the airway, it itself is going to serve the purpose in saving the life of the patient. Okay, so people used to die maybe 3 4 decades back with OP poisoning because of the lack of availability of the mechanical ventilator and all. So that's why OP poisoning is one toxidrome where we can save the patient, okay, with the adequate respirator support and with adequate antidote and all. So next is breathing. Administer 100% oxygen. Evaluate for bronchoria, bronchospasm, respiratory muscle weakness. So ABG, you might expect some sort of type 2 respiratory failure. By the time they accumulated carbon dioxide, it may be significant respiratory failure already there. So prepare for like ventilator strategy if you intubate this particular patient. So circulation, check for heart rate and blood pressure. Bradycardia and hypotension is common in OP poisoning. Obtain at least 2 good IV line, IV access. So give 10 to 20 ml per kg of the crystalloid if no other confounding comorbid condition. A patient is hypotensive. Attach continuous ECG because risk of arrhythmia, QT prolongation is there with some of the OP compounds. So get some idea about the disability like immediate neurological assessment, that is the GCS. So check for convulsions or fasciculation because of the nicotinic effect. Rule out the co-ingestion. So in Indian scenario, many patients with OP, most commonly they take alcohol or other sedative agents and all. You should have that co-ingestion idea. So exposure and environment factor, remove the contaminated clothing. Very, very important. Okay. So wash the skin thoroughly with soap and water. Protect the healthcare workers with proper PPE. Okay, if the OP is still active, still smell is there and contaminated cloths patient came into your ER. So this is critical because OP compound so absorb transdermally also. If you don't take care of yourself, there is a possibility you can get toxicated. So because it's going to absorb through the skin readily. That is for the OP poisoning. So immediate antidote strategy. So one, you are taking care of A, B, C, D, E. So antidote is very, very mandatory. Atropine, which is helping in muscarinic blocker. So start a IV dose like IV bolus of 2 to 3 milligram. So double the dose every 5 minutes until atropinization is achieved. So clear lung field, heart rate more than 80. So SBP, that is systolic blood pressure is more than 80. Dry axilla, so adequate oxygenation. So remember, like pupil dilated, heart rate, systolic blood pressure is not the standalone criteria to tell adequate atropinization. There should be clear lung fields. Bronchial secretion should be dried up. Axilla should be dry. Okay, this is very, very important. So oximes, like start early before enzyme aging. So give a dosage of 30 milligram per kg IV bolus, that is and followed by continuous infusion, that is for the parallel oxime. But we have some specific indication for oxime where to be given, where not to be given. We'll discuss later. So investigation parallel. So you send like at least ABG, ECG, serum electrolyte, blood glucose. So chest X-ray and other supportive like CBC if patient is aspirating, referred from other hospital. So renal liver function test if patient was an ethanolic. So toxicology screen if you suspect some mixed ingestion is suspected. So ongoing monitor. So like monitor for the atropine toxicity like hyperthermia, tachycardia, absent bowel sound. So subsequently later intermediate syndrome, delayed polyneuropathy and all. So next your viva question. So when should cholinesterase level be sent? So what are the limitations of relying on pseudocholinesterase level values in the management of OP poisoning? So can normal cholinesterase level exclude the OP poisoning? So explain with the rationality. Okay. Definitely your viva is going to be like in and around cholinesterase, pseudocholinesterase, true cholinesterase, how to send and all those things. So this next upcoming slide is very, very important. So handling, interpretation, clinical use of pseudocholinesterase versus true cholinesterase. So pseudocholinesterase is also called as plasma cholinesterase. True cholinesterase is also called as so RBC acetyl cholinesterase. Okay. So like where it is produced. If you see, so pseudocholinesterase It is produced in liver, released into plasma. True cholinesterase found in RBC membrane, neuromuscular junction, and the CNS. So sample type pseudocholinesterase send in a plain tube or apernized plasma, send immediately to lab. So true cholinesterase whole blood with RBC suppression you need to send. So handling requirement. Pseudocholinesterase avoid hemolysis, transport quickly, label as suspected OP poisoning. So again, true cholinesterase must be processed immediately. So if delayed, it's going to have some sort of instability and all. So effect of OP poisoning. So pseudocholinesterase is the early marker to fall rapidly. So true cholinesterase decreases more slowly but correlate with the severity. So when to send? So pseudocholinesterase in the emergency department arrival as a baseline. So maybe we can take a call on repeating at 24 hours. But it may not be mandatory if you have a clarity on your diagnosis as a OP poisoning. Okay. So true cholinesterase, when you are assessing the severity, respiratory risk, and guiding oxime therapy, in severe cases, we can take a call on sending true cholinesterase. So turnaround time, pseudocholinesterase is faster, true cholinesterase getting the report itself is slower. So what it indicates, pseudocholinesterase like low level, it is the exposure marker, presence of OP in the system. It tells about so patient is being exposed to OP or not. So there the decrease in pseudocholinesterase will be there. So true cholinesterase tells about the severity and correlation with a neuromuscular failure. So this is your Viva question. Okay. So recovery pattern, if you see pseudocholinesterase recovers to normal in 7 to 10 days. So it takes 2 to 4 weeks for true cholinesterase. So clinical utility, pseudocholinesterase good for diagnosis but poor for monitoring the severity. True cholinesterase good for prognosis. So intermediate syndrome risk. So ventilation duration. So it tells about the prognosis overall. So normal value of pseudocholinesterase is around 4,000 to 10,000 international units per liter depending upon the lab. Again, true cholinesterase is 3 to 10 units per ml. So limitation, pseudocholinesterase can be low in pregnant patient, malnourished patient, liver disease patient as a falsely low pseudocholinesterase will be there. So true cholinesterase, the problem is harder to process and it is not widely available in many of the lab and all. So it's very difficult to get it done. So that is the take home on the pseudocholinesterase versus true cholinesterase. Again, so in summary, so practical applications, limitation, when it helps. So this is one table for your exam ready clinical point. So when to send the cholinesterase level. So why send it early? What does low pseudocholinesterase indicate? What does low RBC cholinesterase indicate? So clinical application, limitation, practical ICU takeaway. So what is pseudo low level? So when not to rely on cholinesterase level. Okay. So one of your take home message. You can just go through this. So again, this table is very, very important for answering many of the Viva based questions which are going to be roaming around pseudocholinesterase and true cholinesterase. Very, very important. See, some examiner particularly interested to know your knowledge on all these things. Okay. So next, move on to the next Viva question. Can you compare atropine versus glycopyrrolate in OP poisoning? Okay. Means what exactly is the antidote? What are the limitations of glycopyrrolate? So what is the mechanism of action of atropine and all those things. Okay. So if you see the comparison in OP poisoning, so blood brain barrier penetration, yes, atropine will have that effect, central effect. So glycopyrrolate will not have a blood brain barrier penetrating ability. It is acting only peripherally. So effect on CNS muscarinic symptom, effective for atropine and it is ineffective for glycopyrrolate. Effect on airway secretion, so strong action, rapid drying from the atropine. So good with the glycopyrrolate, but the action is slower. So effect on bronchospasm. So better with the atropine due to both central and peripheral action. So glycopyrrolate, so helpful, but it is a less robust effectiveness. So atropine, heart rate response significantly it increases, helps in bradycardia. Glycopyrrolate, moderate increase in heart rate. So antidote as a primary recommendation is for atropine is the first line. So glycopyrrolate definitely not as a first line, it is an adjunct only. So role in severe OP poisoning, it is a life-saving antidote when it comes to atropine. So it is an optional add-on when it comes to glycopyrrolate. Advantages of atropine, work centrally and peripherally, rapid reversal of the bronchoria, and it also treat bradycardia significantly. Glycopyrrolate, no CNS toxicity. This is one of the advantage. Less tachyarrhythmia, useful if atropine delirium occurs as an alternative, we can use the glycopyrrolate. So disadvantage of atropine, so definitely it causes CNS toxicity like atropine psychosis, delirium, agitation, hyperthermia. So glycopyrrolate cannot treat the CNS effect. So that is a disadvantage. So not sufficient in severe OP poisoning, OP crisis. So clinical use of atropine. So titrate to atropinization, that is a dry lung, heart rate, blood pressure, pupil, all those things are your endpoint for atropinization. So glycopyrrolate used when atropine toxicity limits the dosing of atropine. So why atropine is preferred? Only drug that reverse both central, peripheral, muscarinic toxicity. So glycopyrrolate only peripheral effect. It is inferior for severe poisoning. What is the evidence? So there are some data available. So if you see like one clinical trial suggests atropine faster airway secretion control and improved oxygenation. So other data superior clinical outcome combination therapy shows no survival advantage over atropine alone. So alone is okay, no need to club with atropine the glycopyrrolate. So again one of the ICU cohort study atropine earlier we are able to achieve the atropinization and reduce the ventilator days with the atropine. So glycopyrrolate the data when they compared, so glycopyrrolate reduced the salivation, but not deep airway secretion. Okay. Again, no mortality benefit with the glycopyrrolate. So no reduction in atropine dose requirement when you add glycopyrrolate to the atropine. So that is not needed as giving a combination therapy. Again, so slower respiratory improvement as compared to atropine, that is with the glycopyrrolate. Very, very important. Again, lots of viva can happen in this area. So, what are your targets of atropinization? So, as I already told, drying of secretion, especially lung, pulmonary secretion, heart rate more than 80, systolic blood pressure more than 80 to 90, pupils no longer pinpoint, chest is clear on auscultation. So, we give 2 milligram IV every 5 minutes. So, double each time until you achieve the atropinization goal, followed by infusion of 10 to 20% of the total atropine per hour. Means like to achieve your the goal of atropinization, the atropine needed is 10 milligram, so around 2 milligram, that is the 20% per hour, you can continue as an infusion. So that is the typical answer you can tell you in your viva. So when should oximes be given, like pralidoxim or obidoxim? So what is the indications for the oximes? Okay, so when to give? Moderate to severe OP poisoning. So nicotinic features are present like fasciculation, muscle weakness, respiratory muscle failure. So it is the strongest indication for giving oximes. So early presentation after ingestion. So before aging occurs ideally within 24 hours up to 48 hours depending upon the type of the OP. But definitely within 24 hours is the ideal. So when we have a confirmed suspected true OP compound, especially diethyl OP compounds like chlorpyrifos, parathion, better response with the oximes. At least remember diethyl OP compounds. So persistent symptoms despite the atropinization. So if they are having a muscarinic improvement but ongoing weakness, so that explains there is a ongoing nicotinic feature. So then oximes must be continued. So impending or established respiratory failure like diaphragmatic involvement, intercostal muscle weakness. So it is a nicotinic problem. So then also it is better to give the oximes. So when not useful, definitely carbamate poisoning. Okay, so acetylcholinesterase inhibition is reversible. No need to give the oximes there. So if aging is complete, oximes cannot reactivate acetylcholinesterase. So if aging, that complex aging is already over. So when patient is having a pure muscarinic symptoms, so that are well controlled with atropine alone, so then also may not be required to give the oximes. Okay, so again the rationality for giving oximes plus evidence summary. So reactivation of acetylcholinesterase. So oximes dephosphorylate the OP inhibited acetylcholinesterase and restores the enzyme activity. So the reversal of nicotinic toxicity, only therapy which improves the neuromuscular transmission and improves respiratory muscle strength. Okay, so it prevent enzyme aging, must be given early. Aging makes acetylcholinesterase inhibition irreversible. So reduce the duration of respiratory failure, it improves the muscle power, reduce the ventilation need. So complement to atropine treat muscarinic symptom, enzymes treat nicotinic dysfunction. Okay, so if you see the evidence backup, so one of the clinical toxicology review, so early enzymes improve neuromuscular recovery, ineffective if given after aging of the enzyme. So one more Sri Lankan OP cohort study, so clear benefit in diethyl organophosphate poisoning, so limited effect in fast aging, that is dimethyl OPs. So again, one more ICU OP series, clinical series study, earlier recovery, better diaphragm function when enzymes are used early. So what is the WHO positioning on enzymes? It is strongly recommended for enzymes in all moderate to severe OP poisoning, especially when they have a nicotinic manifestation with the weakness. That is the WHO position statement on using the enzymes. So remember, so some of the questions may like roam around the OP compounds to check what is your knowledge on different OP compounds and their aging time and all. So diethyl OPs, we have chlorpyrifos, parathion, diazinon, so quinolphos, 4-8, slow aging, that is like 12 to 48 hours aging time. So excellent response to oxime therapy. Oximes are strongly recommended. So dithiophosphat OPs, it is a subset of diethyl. So that is malathion, phenethion, slow to moderate aging, good response to oximes. Okay, dimethyl OPs, so that is monocrotophos, dichlorophos, so oxidimeton, methyl methamidophos, very fast aging, like within minutes to 3 hours, poor response. Oximes only useful if given extremely early. So high lipid soluble OPs like chlorpyrifos, phenethion, tricloferan, so slow release and prolonged toxicity, oximes may be beneficial. So like extended use may be beneficial if the like compound OP compound is highly lipid soluble. So carbamates, these are the not true organophosphates like carbaryl, so carbofuran, propoxur. Okay, so no aging. So reversible inhibition is there. It is not a irreversible inhibition. Oximes not recommended. No benefit, may worsen the scenario. That's why no indication of giving. So oximes in carbamate toxicity. Okay. Again, this is the table which tells about the dosing of commonly used pralidoxime and obidoxime. So pralidoxime like 30 milligram per kg IV, maximum 2 gram over 20 to 30 minutes bolus, maintenance infusion of 8 to 10 milligram per kg per hour. So that is approximately 500 milligram per hour. So up to 5 to 7 days in severe OP poisoning or maybe 24 to 48 hours. So avoid rapid bolus of pralidoxime because patient can have arrhythmia and hypotension, cardiac arrest. Always give with the atropine, very, very important. Obidoxime, 250 to 500 milligram IV bolus for 20 to 30 minutes. So then 750 milligram per day in a divided or continuous infusion. Duration may be up to 48 hours. Better for diethyl organophosphate compounds, not recommended for dimethyl OPs. Okay. Again, WHO also give some alternative pralidoxime regimen, 2 gram IV loading over 30 minutes. Okay, so 1 gram every 1 hour. So into two doses, then 1 gram every fourth hour up to 48 hours. Used in resource limited setting when you have a problem with giving it as a continuous infusion. That is the WHO recommendation for pralidoxime as a alternative regimen. So very, very important. So this is the dosage table. So this is one landmark trial you should remember. So that we call it as a Pawar trial, Kirti Pawar trial or Baramati trial. It is an Indian based study. So continuous parallelism infusion versus repeated bolus injection to treat organophosphorus pesticide poisoning. It's a randomized control trial which got published in Lancet in 2006. So they included around 200 patients. So interpretation, if you see high dose regimen of parallelism consisting of a constant infusion of 1 gram per hour for 48 hours after 2 gram loading dose reduce the morbidity and mortality in moderately severe cases of acute organophosphorus pesticide. So this is the inference. So just for your viva purpose, remember this clinical trial. Many times it is been asked in your practical exam. Very, very important. Okay. Coming back to our patient. So clinical deterioration. Day 2, patient shows worsening of respiratory distress. His respiratory rate is 34 minutes, is saturating 88% on 10 liter per minute via face mask. So there are copious secretions. His GCS become E1, V1 and M2. Okay, this is the ABG. So on 10 liter, pH is 7.22, PCO2 is started retaining, it becomes 62, PaO2 58, and FiO2 of around 60%, bicarb is 25, SaO2 is 86, lactate is 2.8, A gradient markedly elevated. Okay, so we decided, so he needs an intubation and mechanical ventilation, so sedated and continued on atropine infusion with a praldaxin. So next your Viva question, what are the indications for intubation and mechanical ventilation in OP poisoning? So if patient on atropine, many a times it is a real problem. If patient is persistently psychotic, persistently delirious, what options you have to treat that, like ICU delirium which is related to atropine? Okay, so how you are going to address this problem? So these are the two important questions examiner will ask you. So management of atropine-induced delirium or psychosis, reduce the atropine dosage, switch or add glycopyrrolate so that like we can come down on atropine. So non-pharmacological measures, like if patient is bit okay, you can try to reorient, sleep hygiene, so minimize the noise. So all these things, non-pharmacological things you can try. So antipsychotics preferred is haloperidol, low dose ergotamine, but like these things does not worsen the anticholinergic toxicity, haloperidol and quetiapine. So dexmedetomidine, low dose infusion if severe agitation, so it gives a sedation without any respiratory depression. Benzodiazepines use cautiously, sometimes may worsen delirium, because we know that benzodiazepines are the independent risk factor for delirium. So reserve for when patient is having some central manifestation like convulsion or extreme anxiety, so then you can use the small dose of benzodiazepines. So physostigmine rarely used. So like expert only use, generally avoided in OP poisoning due to risk of sudden bradycardia and convulsion. So these are some of the strategies you can add on in your management when patient is having OP induced delirium or psychosis. Okay. So what are the indications for intubation and mechanical ventilation? For airway protection, loss of protective reflex, GCS is less than 8, inability to handle the profuse secretion, high aspiration risk due to vomiting or altered sensorium. So respiratory failure, when they are having a severe muscarinic manifestation, severe bronchoria, okay, not controlled by atropine, severe bronchospasm with hypoxia, so persistent like saturation more less than 90% despite oxygen therapy. So remember, the mortality in OP poisoning is because of asphyxia, not because of bradycardia and all. Okay, that is because of the severe bronchoria. Or if patient is having respiratory failure with nicotinic manifestation like respiratory muscle weakness, diaphragm, intercostal weakness, so neck flexor weakness, poor head lifting, weak cough, inability to clear the secretion. So tachypnea, like respiratory rate is 30 to 35 per minute. So ABG showing type 2 respiratory failure or impending type 2 respiratory failure with rising PCO2. CNS involvement like convulsion, status epilepticus, post-ictal suppression of the airway reflexes. So cardiovascular instability. Some OP can have severe bradycardia with hypotension and they are requiring shock, means shock needing the vasopressor. In that scenario, you can take a call on intubation. So or later, if they have intermediate syndrome with a bulbar weakness, proximal limb weakness, respiratory muscle paralysis and all. So the objective criteria, vital capacity, if it is less than 15 ml per kg or negative inspiratory force of more than minus 20 centimeter of water, so then which suggest as an objective criteria for intubating and mechanical ventilation. Okay. So our patient, so day 3 to 5, ICU management is stable on ventilator. So atropine maintained at a dose of 1 to 2 milligram per hour. So pralidoxime has been continued. So we initiated him on the Riles tube feeding. Okay. So, but the problem, he got a gastric residual volume of around 900 ml in the 24 hours. So secretion load is reducing, but is still having a so high gastric residual volume, that is around 900 ml in 24 hours. So what is this? What is the concern? Okay. So for initiating enteral feed in patient, how to troubleshoot this problem? So when patient is having OP poisoning with atropine, okay, so what is the thought process on feeding, whether it's a contraindication, absolute, relative contraindication, what precaution, how to troubleshoot. Okay, so feeding is not absolutely contraindicated while on atropine. So the concern is relative, not absolute. Okay, so atropine may cause ileus, delayed gastric emptying and aspiration risk. Therefore, initiate feed cautiously. So when airway is protected, okay, intubated or like is able to clear the airway, secretions are controlled, bowel sounds present or gastric residuals are acceptable. But this last like point, like bowel sounds present, is one of the relative phenomenon. So if patient you are able to protect the airway, you can try the feeding even though patient is not having a bowel sound. So that is the take home here. Okay. In summary, feeding is allowed but must be cautious, not an absolute contraindication when patient is on atropine infusion. Here our patient, he had 900 ml in 24 hours. That is around near to 37 to 40 ml per hour. So not a single high gastric residual volume. So it is not a contraindication here. Okay. So do not stop the feed. So solely based on gastric residual volume. Assess for clinical intolerance because patient on atropine so will have delayed gastric emptying that is expected. So maybe you can start him on prokinetic. So switch to post pyloric feeding if patient is having a persistent, so like some sort of the problem with intolerance. So correct the metabolic factors, ensure optimal sedation, so position of the Rayleigh tube, so cross check the Rayleigh tube position, all those things you need to take care. So because remember the normal respiratory secretion means like gut secretion itself is around like 70 to 80 ml per hour. So if we have say 250 to 300 ml at the end of 4 hours, so there is no need to stop the feeding. So no consensus on gastric residual volume aspiration every fourth hourly, every hourly. So that is not recommended. Very, very important. Okay. So what do guidelines say about the gastric residual volume? So Aspen guidelines do not routinely check gastric residual volume if used. So allow gastric residual volume up to 500 ml before holding the feed. So high gastric residual alone does not predict the aspiration. Stop feed only if you have more than 500 ml and patient has a clinical signs of intolerance. Otherwise, you can start them on prokinetic and you can continue the feeding. East Pain guidelines. So GRV monitoring is optional. So threshold of more than 500 ml to hold the feed. So GRV monitoring should not be used to guide routine feeding interruption. Use prokinetics when GRV is repeatedly more than 500 ml. Okay, like erythromycin or metoclopramide you can use. Again, Canadian critical care guidelines, GRV is not recommended on a routine basis. So basically the GRV, there is no consensus on checking the GRV routinely in your ICU patients. Very, very important because here I particularly put this question. So your examiner might be interested to divert some sort of like regular questions into out of the OP discussion and all. So that's why this part is very, very important. What is your plan for tapering atropine and enzymes? So again, back to our management of the OP. So how you are going to taper and stop atropine and enzymes. Okay. So atropine, once atropinization is stable for 12 to 24 hours. So then we can take a call on tapering the dose if patient is having a clear lung field, no bronchoria, heart rate BP is more than 80. So how to taper? Reduce infusion rate gradually over 12 to 24 hours while monitoring the secretion and vitals. When to stop? Stop when patients remain stable 6 to 12 hours after complete cessation with no recurrence of secretion or bradycardia. So atropine tapering must be slow. Early stopping, there is a high possibility of the rebound cholinergic crisis. So enzymes after 24 to 48 hours of the treatment and clear improvement in muscle strength, fasciculations are not there, respiratory efforts are good. So then switch from continuous infusion to intermittent dosing or stop directly if patient is having a clinical improvement of the nicotinic symptoms. So usually stop at 48 hours. So may extend to 5 to 7 days in severe cases. Those are lipid soluble organophosphorus like chlorpyrifos. So enzymes help in nicotinic symptoms continue long enough to avoid respiratory muscle weakness as a relapse. Stop after clear neuromuscular recovery. So other consensus is when atropine is being stopped at least for 12 to 24 hours, then you can take a call on stopping the enzymes. Okay. So these are some of the recommendation which you can remember for your exam purpose. Day 6, patient got extubated, but the problem was like post extubation. So his PCO2 is 34, pH is 7.46, PO2 is 58 and 80% of so NRBM. So bicarb is 23, SaO2 is 88 to 90, lactate is 1.8. So A gradient very high, PF ratio is 72. Along with that, he developed floppy neck. Okay, neck is flop, difficulty in breathing. His respiratory rate is 42 per minute. So SpO2 is around 90% on NRBM. So ABG shows hypoxia with a normal CO2. Pupils are normal. Heart rate is 96 beats per minute. What is your differential diagnosis at this level? Okay, so day 6. So he got re-intubated, still having some problem in terms of some neuromuscular like manifestation. What is the problem here? Okay. So here the differential diagnosis we should have as the primary DD is intermediate syndrome. So neck flop. So some of the supporting features like flop neck. So proximal weakness, shallow breathing, which occurs 24 to 96 hours post ingestion. So usually you extubated and require the re-intubation. So somewhere maximum in and around 5 to 6 days, you suspect intermediate syndrome. Most common cause for re-intubation. So neuromuscular junction dysfunction is the problem here. Okay. So other things, residual central effect of OP itself, like CNS depression, they will have a altered mentation, poor airway reflex. So again, so can cause inadequate airway protection even after muscarinic signs are resolving. Means even secretions are drive because of the central manifestation of the OP. So again, they might require the reintubation or a recurrent cholinergic crisis. Like again, so there is an increase in secretion, meiosis, bradycardia due to premature atropine tapering or redistribution of the OP from the like fat store. That is a highly lipid soluble OP can give rise to again cholinergic crisis. Then they might require the reintubation. Atropine toxicity. So agitation, hyperthermia, ileus, tachycardia can cause failure to protect the airway or reduced respiratory drive. So other indications for like reintubation and the differential diagnosis when we have extubation failure is, so patient might have aspiration pneumonitis, pneumonia or ventilator associated pneumonia, upper airway obstruction, that is a post extubation stridor, so respiratory muscle fatigue. It may not be OP induced because of malnutrition, electrolyte imbalance. So metabolic causes, okay, acute lung injury or patient is having a severe ARDS manifestation with a background of aspiration pneumonitis or pneumonia. So these are the other so causes for extubation failure and the differential diagnosis with the early post extubation failure in OP poisoning. So at least you should remember these differential diagnosis. So next your important Viva question. What is intermediate syndrome? How will you manage and comment on the prognosis when patient is having an intermediate syndrome? What exactly is the intermediate syndrome? So IMS, that is intermediate syndrome, is a delayed neuromuscular weakness that occurs typically 24 to 96 hours after OP poisoning, after the initial cholinergic crisis has resolved and before the onset of OP-induced delayed neuropathy. So after 96 hours, means after day 4, usually we see this. Okay, it is due to persistent nicotinic receptor dysfunction at the neuromuscular junction. So the pathophysiology, so IMS is caused by prolonged overstimulation and desensitization of nicotinic acetylcholine receptors at the neuromuscular junction, leading to failure of respiratory and proximal muscles. So unlike cholinergic crisis, atropine does not help here. So IMS, so unlike OP-induced delayed neuropathy, IMS is reversible, so not having any axonal degeneration. Very, very important. Okay. So again, if you see the clinical features, so in terms of muscles, they have a neck flexor weakness. We call it as a neck flop, proximal limb weakness, shoulders and hip girdle, respiratory, diaphragmatic and intercostal weakness, tachypnea, shallow breathing leading to respiratory failure, bulbar, so weak cough, weak gag reflex, difficulty swallowing, risk of aspiration will be there, autonomic, minimal or absent muscarinic symptoms. So pupils usually normal because it is the problem with the nicotinic, not the muscarinic. Mental status usually normal, no central cholinergic crisis will be there. Very, very important hallmark signs of intermediate syndrome. So if you see the duration and prognosis, so ventilation is needed. So usually up to 2 to 3 weeks. Okay. So definitely they will recover fully. Excellent once neuromuscular junction is resensitizes. Okay. So mortality linked to delayed recognition and aspiration. Not intermediate syndrome per se is the cause for mortality. But if you recognize it very delayed and patient had other sequelae like aspiration and all, so then it leads to morbidity and mortality. Okay. So again, in terms of therapy management, early recognition is very important. Secure the airway and ventilation with immediate intubation, mechanical ventilation. Atropine use continue only if patient is having some sort of cholinergic manifestation, muscarinic manifestation like secretion, so bradycardia. Otherwise, atropine does not treat the intermediate syndrome. So it is nicotinic, not the muscarinic is the problem. Okay. Oximes limited benefit once IMS has developed. So continue only if prescribed earlier. So may help in preventing IMS, but not the reverse. Okay. So that's why oximes may not be the drug of choice for intermediate syndrome. So physiotherapy, chest physio, limb physio, prevent atelectasis and promote muscle recovery, prevent the complication like other DVT prophylaxis, nutrition, so pressure sore prevention and all. Treat precipitating factors like hypokalemia, hypomagnesemia, calcium, treat the infection. So then we should have a appropriate weaning strategy, slow weaning. Okay. So intermediate syndrome recovery takes days to weeks. So that you need to remember. Don't attempt weaning immediately when patient is having a intermediate syndrome. First and foremost, recognize and protect the airway with intubation and mechanical ventilation. Very, very important. Okay. So how will you differentiate between cholinergic crisis versus intermediate syndrome versus OP-induced delayed neuropathy? Again, so this table give a some sort of concise overview on the cholinergic crisis versus intermediate syndrome versus OP-induced delayed neuropathy. Remember, so duration, time onset, okay. So underlying mechanism, muscarinic signs, nicotinic signs, CNS signs, respiratory failure, type of the respiratory failure, pupil, so response to atropine, response to oxime, treatment option, duration, which is going to persist, prognosis. So all these things are very, very important subheadings when you answer the difference between intermediate syndrome, cholinergic crisis, and OP-induced delayed neuropathy. So I'm not going to read out all these things. Just go through this important table. Very, very, very important. Okay. Very, very important. So coming back to our patient, day 7. So continued on mechanical ventilation. Is still in the intermediate syndrome phase. So the patient remains intubated with ongoing proximal muscle weakness and neck flop. Vitals like heart rate is 98 per minute, BP 112 by 68. So respiratory rate on ventilator we kept 16 per minute, saturating on 96% on pressure support. So is requiring pressure support of 12, PEEP of 6, FiO2 is 40%. Secretions are moderate, non-frothy, pupils are normal. So atropine infusion tapered to minimum. So oximes has been discontinued. So stable gas exchange, persistent weakness in the neck flexor or shoulder girdle. So improving oxygenation, but respiratory muscle power is inadequate for independent breathing. Okay. So at day 8 to day 10, so we attempted the weaning trial but failed. So a pressure support weaning trial subsequently. So pre-trial vitals were okay. So within 15 minutes of weaning trial, so respiratory rate increased to 34, saturation decreased to 92%. So axillary muscles usage was noted. So patient appeared to be fatigued. So what is the important predictor of weaning failure in OP poisoning? What bedside signs objectively helps to decide not to attempt further weaning? So remember, so objectively, so respiratory muscle weakness from intermediate syndrome. So we can predict poor negative inspiratory force, low vital capacity, tachypnea. So neck flop, rapid shallow breathing, and weak cough with a negative inspiratory force of -20, more than -20, vital capacity of less than 15 ml per kg. So these are some of the bedside objective signs. It doesn't make sense to repeatedly attempting the weaning. So he's going to have a significant weaning failure because of the intermediate syndrome. So these are objective, like answer you can tell in your Viva exam. Day 11, so we performed the tracheostomy. So due to repeated weaning failure and ongoing intermediate syndrome, a percutaneous tracheostomy is done. So post tracheostomy, pressure support 10, PEEP of 5, FiO2 is 35. So patient is more comfortable, less work of breathing, early phonation and feeding plan initiated post evaluation. Means we thought, okay, we'll go for initiating some oral feed with the tracheostomy tube. So why tracheostomy performed in prolonged IMS ventilation? So it reduces the work of breathing, improves comfort and secretion clearance, So facilitate the weaning, reduce the airway injury and sedation requirement. This is your answer. So why you perform the tracheostomy in a OP patient with intermediate syndrome. So day 12 to day 24, gradual strength improvement and pressure support like weaning has been put. So clinical course, shoulder and neck strength begins to return. So better cough effort, improved respiratory mechanic. Vitals on day 14, heart rate 88. So respiratory rate is 20, saturating and TPs. So around 98% on 1 to 2 hours of the TPs trial, able to tolerate the TPs and pressure support. We electively put him back on pressure support in the night. So shifted to ward on day 14 with a tracheostomy tube inside too. So next day 15 to 21, end of third week, so patient started to have distal weakness. So foot drop pattern, so decreased ankle reflexes, sensory symptoms like paresthesia in the feet, so gait instability. If walking is attempted is having a gait instability. So what is the problem here? What's happening? So he improved, shifted to ward, and somewhere around in and around 3 weeks, he started having all these clinical manifestation. What is wrong here? Okay. So basically, this is where we have OP-induced delayed neuropathy as the first differential diagnosis. So this is the summary. You can just see the delayed distal sensory motor axonopathy, which is occurring somewhere at the end of 3 weeks or 1 to 3 weeks after OP poisoning. So that is what is the OP induced delayed neuropathy. So typically it occurs 7 to 21 days, can appear up to 6 weeks in the post exposure. Underlying mechanism is the irreversible inhibition of something called neuropathy target esterase. So that leads to axonal degeneration. That is a Valerian type degeneration in the long nerves. So pathophysiology, distal involvement is more as compared to proximal axonal injury. Motor involvement is more as compared to sensory involvement. So demyelination is less prominent. It is the axonal degeneration is the problem. So common OP agents which cause OP-induced delayed neuropathy like chlorpyrifos, so triclofuran, TOCP, that is triorthocresyl phosphate, melathion and phenethion. So clinical feature, distal weakness, there is a foot drop pattern, gait instability, difficulty in walking or steppage gait. So hyporeflexia, areflexia, especially in the ankle. So distal sensory loss, paresthesia, no respiratory muscle weakness, unlike intermediate syndrome. Very, very important differential. So normal pupils, normal vital, normal mental status. Okay. So if you done a nerve conduction study or EMG, ENMG, so there is an axonal neuropathy pattern, decrease in amplitude potential with preserved conduction velocity. Okay. So we should differentiate it from intermediate syndrome. Usually IMS origin is 24 to 96 hours OP exposure. So proximal and respiratory muscle weakness will be there in IMS, no sensory loss. So in OP-induced delayed neuropathy, typically it is beyond 7 to 21 days. Distal sensory motor neuropathy, no respiratory failure. Very, very important differential. Okay. So therapy, no specific antidote for OP-induced neuropathy. Physiotherapy, rehabilitation, occupation therapy. So analgesics for neuropathic pain like gabapentin, pregabalin, nutrition support with a vitamin B support is needed for OP-induced delayed neuropathy. So prognosis, gradual recovery over months. So we have a couple of patients who took almost 7 to 8 months and all for the total recovery. So some patients may have persistent mild distal weakness also that we need to keep in mind. So take home message, OP-induced delayed neuropathy is a late axonal neuropathy caused by like some sort of neuropathy target esterase inhibition, which appears 1 to 3 weeks after poisoning, managed with supportive rehabilitation, not with atropine, not with oximes. Very, very important table. Okay. So coming back to our patient, so day 22 to 28, recovery phase and decannulation. So if you see the progress of our patient, respiratory muscle strength normalizes, neck holding regained, so negative inspiratory force improved to minus 32 centimeter of water. So vital capacity around 20 ml per kg. TP is tolerated more than 12 hours. So tracheostomy decannulated around day 26 to 27. So day 28 we discharged, ambulating with support. Mild distal neuropathy still persists. Home exercise rehab plan has been given. Okay. So here patient gone through cholinergic crisis, intermediate syndrome, OP-induced delayed neuropathy. Okay. So these are the key features, timeline. So you can just go through this table. So as our patient gone through all the phases. So including ADA, like intermediate syndrome and delayed neurotoxicity. So very, very important. Your Viva definitely take you through all these important questions when you answer for a case-based OP poisoning. Okay. So this is one last table. See, there are some novel adjunctive therapies in OP poisoning tried, but nothing proven on paper in terms of the evidence. So magnesium sulfate, so presynaptic inhibition of acetylcholine release, and it helps in membrane stabilization. So evidence is small. RCTs and observational studies shows decrease in atropine need or decrease in arrhythmia incidence. So like it is an adjunct only, not a standard of care. So benzodiazepines in the early use, so they have a GABA agonism, reduce the CNS excitation and seizure potency is going to be reduced. So possible neuroprotection, strong evidence for seizure control, animal data for neuroprotection, recommended early only if patient is having a CNS toxicity, otherwise not on a routine basis. So FFP, it provide exogenous cholinesterase to bind the organophosphorus. Only we have some case series. So inconsistent benefit, not routinely recommended. Okay, because see, plasma is having a cholinesterase. So the problem is like we have a cholinesterase. Why can't we give the cholinesterase externally? That is the rationality. Okay. So human butyryl cholinesterase. So that is a bioscavenger, recombinant butyryl cholinesterase. So it is a circulating enzyme which binds to OP before it reaches the synapses. So it is still experimental and military research. It is promising but not clinically available. So sodium bicarbonate, that is alkalization, it increases the OP hydrolysis, reduce the toxicity, stabilize the myocardium. Again, limited human studies may help in severe acidosis but not a standard therapy. So NMDA antagonist like ketamine, again it reduces the excitotoxic neuronal injury, only animal data. So not routine, only theoretical benefit. Antioxidants like vitamin C, vitamin A, it reduces the oxidative stress from OP toxicity. Okay, so small studies, weak evidence, it is only adjunctive, no outcome benefit is been proven. So hemoperfusion, extracorporeal removal, it removes the lipid soluble OP compounds. Again, case reports only available, limited clinical trial, consider only in a massive injection of the lipid soluble OP compound, otherwise not as a routine. Clonidine they tried, so it reduces central sympathetic overactivity. So only data is very sparse, not recommended routinely. Physostigmine, so it is a reversible acetylcholine esterase inhibitor. So that is paradoxical, unsafe in OP poisoning, it is contraindicated. Okay. Even patient, they try to use in atropine induced agitation, but very, very limited role because it may cause severe adverse effect and all. So neuromuscular blockers, so it facilitate the ventilation, supportive ICU care, does not treat the toxicity. So remember at least magnesium sulfate, clonidine, FFP, recombinant butyrylcholinesterase, all these things are asked in your Viva exam. So that's about the discussion on case-based approach to organophosphate poisoning. So we'll come back with many more cases. Till that time, revise.